Good afternoon. Welcome to the webinar. Before I get started, just a couple of things so that we don't have to get 100 questions about this. You don't have to be sitting there taking pictures of the screen of all the slides. We will be sending out the slides and a recording tomorrow. If you want to ask questions, you can send the questions. Historically, we don't get to the questions during the webinar because we have a lot of ground to cover, but we will respond to them after. Also, I just want to apologize. I know we were supposed to have this webinar a couple of weeks ago. I was not feeling well, so was not able to do it, but thank you for joining again today. Okay, so what we're going to talk about today is preparing for an OSV. So as you probably all know, about 3 years ago, HRSA came out with a new compliance manual, which is actually very helpful in the sense that until then, there were many different documents and many different PINs and PALs and things like that that govern what was supposed to happen. And if you became an FQHC in 2017 and you were governed by some documents that were issued as early as 1998 before the internet, and now you're trying to comply with them, it's very hard when you don't even know that document exists. And so what they did is they came out with the compliance manual, which is now supposed to be where you need to look for everything. So that's one positive factor. A second positive factor is that the stated goal in coming to the compliance manual was to have an even playing field for everybody, meaning that until the compliance manual, the reviews were very subjective, right? So anyone who's not gone through a review before, the way it works is there are 3 reviewers that come on site, one who focuses on governance, one focuses on clinical, one focuses on finance, and those reviewers do not actually work for the government, and depending on the luck of the draw, who you get, you could have reviewers who are very friendly and willing to do things and be sympathetic to your needs, and there are other ones who are just sticklers and say, you know, if you don't have it, you don't have it. And what we had found was that you could literally have, we actually had an example before the compliance manual came out where we had 2 clients who had OSVs the same 3 days and had exactly the same policy. And one of the OSVs, they said it was the best document they've seen, and the other one, they cited them for being out of compliance. And so the stated goal in the new manual is to say, okay, here's the rules, here's what you need to do, and here's the standard we're going to apply, and that should be applied across the board to everybody and take out the subjectivity. In real life, and see some of these statistics when we get to the end, but we've done this for more than like 25 FQHCs under the new compliance manual. There is a lot less subjectivity than there used to be, but there still is subjectivity. So I told you a bunch of the good things. One of the bad things about the compliance manual is that you talk about in life, people worry about form over substance. This is an extreme case of form over substance. So the example that I always give is if one person says Charlie went to the store and the other person says Charlie visited the store, any rational person is going to understand you both saying the same thing. Unfortunately, in the HRSA world right now, if they want you to say Charlie visited the store and you wrote Charlie went to the store, they're going to cite you for being out of compliance. One of the other things that's changed with this, which also makes it more difficult, is it used to be that if the reviewers liked you, they would let you fix small things like that while you're on site and wouldn't cite you for it in the report. Now they have pretty much done away with it. So when they see the document, if it's compliant, fine. If it's not compliant, then you can be found out of compliance. Of course, there is something else which is good, which is they now, at the end of the site review, they will give you a report of what they found and didn't find and tell you what the problems were. And then they also give you a sort of draft or interim written report, which you have 14 days to fix. Anything you fix within 14 days is considered to be in compliance and therefore will not be included in the final report, which we'll talk about whether you're in compliance or not. What they have not changed is the rules that they always applied in the past, which is, right, we're going to go through, there are approximately 20 different categories or 20 different chapters which talk about your compliance requirements. Within each chapter, there could be 5 or 10 or 15 different pieces that make up that chapter. And the way it works is if you're out of compliance with even one part of that, then you're considered to be out of compliance with that element. So right, if you have kids or you were in school, you remember being in school yourself, if you got a 95 on a test, you were very happy with it. In the HRSA world, within each chapter, you either get a 0 or a 100. There's nothing in between. So if you're not perfect, you might be found to be out of compliance on 8 elements, and each one of those elements you only had one thing wrong, right? So you would say because there are approximately 100 different items that make up the 20 different chapters. You would say, okay, you got a 92 on that test, and HRSA is going to say no. That means you failed 12 out of the 20, right? So that you failed 8 out of the 20, which means you got a 60 on the test, not a 92. So it is important to be a stickler for these things and to be prepared in advance. I will tell you that whether it's us or somebody else, it is extremely important that you get someone to help you in preparing for these, because the idea that you're going to be able to do this by yourself and get all the words and get everything down that we're going to go through today, I mean, I don't want to say it's impossible, but it's highly unlikely that you'll be able to do all these things for yourself. One of the slides we'll get to at the end, there are 29 documents that need to be updated based on the HRSA Compliance Manual. So if this is your first time having an OSV under the new compliance manual, there are 29 documents you need to update. If you had one 3 years ago and are having one again, there are fewer documents need to update, but there still are documents that will need updating, like the QA policies and the risk management policies, and we'll talk about those as we go through. Okay, so just so you can see, these are the topics we want to cover today, which are very many, and hopefully we will get through all of them or get through at least something about them. It used to be that I would tell you element 1, 2, 3, 4, right? HRSA doesn't do it anymore. They issued a new manual with many different chapters. Different people will tell you about the different number of elements rather than trying to guess that. We are just going to make reference to different chapters, and you could figure out for yourself how many elements you think there are. Okay, so I'm not going to go through everything in each element. I'm just going to touch on some highlights relating to each of them and try to give you some practical tips. Okay, needs assessment. So you do a needs assessment as part of your application once every 3 years or whatever grant period you have. All right. For the purpose of today's meeting, I'm going to use the word FQHC, but the same thing would apply to a lookalike or a subrecipient. So once every 3 years, you do it. And until approximately the last 12 months, all HRSA really asked to see when they came in is show me you had a needs assessment that you submitted when you did your application and that pretty much satisfied this requirement. That is not the case in more recent reviews that we've been seeing, because what they now want to see is something showing that your board has been involved in determining need. So that could be that you did your reapproval application. If you did it a year ago, you're probably better off than if you did it 2 or 3 years ago. But they also want to see something in the minutes where boards are looking at needs and you're making decisions based on needs and doing things and re-examining needs, not in the context of a formal needs assessment, but just in the context of day-to-day operations on a regular basis, not just once every 3 years. Also, there's a new requirement that the board has to approve your service area, which means the zip codes that you include in your service area for UDS reporting and other reporting. So you actually want to take a piece of paper that has all your zip codes on it, your service area, and stick that in front of the board at least once a year. Okay, so required services. So this is forms 5A, B, and C. According to HRSA, we actually just went through an interesting experience because we had a client that was a startup to become a lookalike, and they had been spun off from a hospital, and so HRSA was very concerned about the hospital's control over their operations and whether they really were a standalone FQHC. So during the site visit, besides the 3 reviewers who came, there actually were 2 senior people from HRSA who came on site to be part of the reviews. And I guess one of the good things about it is it gave us some opportunity to actually ask some questions and get some answers directly from HRSA rather than just from the reviewers who can't really speak from HRSA. And so we got some interesting information that I'll share as we go through the presentation today. But the first thing they said is that Forms 5A, B, and C are the item that is most often out of compliance because they have changed the rules so many times and the rules are just not clear. So I'll go through some of those details. For example, if you are providing services on site, but the provider, the physician or the other provider who's actually performing the services is being paid under a 1099 rather than a W-2, and they are the only person who provides those services. So, for example, you have a social worker. You have a social worker who's providing services, and it's only social worker, and you have a contract with them, or a podiatrist, or any other, one of the items that are listed on Form 5A. And it's only being done, or you have an OBGYN, right? It's a good example. You contract with the OBGYN to provide service, and you pay them on a 1099 basis. That means you're paying them as an independent contractor rather than as an employee on a W-2 basis. HRSA says you only check column 2, right, on the form. You do not check column 1, even though it's being provided on site, because it's being done by an independent contractor. Now, I will tell you that having gone through so many of these reviews, many of the reviewers don't take that view, but this is coming straight from HRSA, and this is their view, at least going forward. And they acknowledge it was unclear, but they, like I said, they said it to us face to face, and that's the way you're supposed to be doing it. Also, so when I talked about before that you have 14 days to fix things, this is the area where you have the biggest problem with satisfying that 14-day requirement. Because if it turns out that your scope is incorrect, and now you want to go fix it, and you have to do a change of scope where you're adding something to column 1 or 2, which potentially could be a full change of scope, you will not be able to do that in 14 days. So if you're starting to prepare, I would say the first thing you want to prepare with is your Form 5A, because that has, like I said, the longest lead time to be able to correct. Other things that go with this form is you need to have something in there for each column that's on the form. Now, if you have column 3 checked off for the form, right, you refer out lab services. One of the things that's changed is you now only need to have 1 lab. But if you have 3 labs, then you will have to be in compliance. So a tip is that if you only have 1 lab contract that's in compliance, when HRSA is there, you want to focus your conversation on this being the lab that we send to, rather than mentioning all the others. If you mention them, then you ask for the agreements. If they're not in compliance, then you're not going to be okay, right? Being in compliance means there have to be certain specific items in that agreement, right? You have to have sliding fee language in it, you have to have reporting language in it, and you have to have referral back language depending on what kind of provider there is. In column 2, you also need to have specific language in there, which is the items from column 3 plus additional language about reporting to you and about providing access to records. And I will tell you that most of the column 2 language does not make any sense when the person is working on site, but if you don't have it in there, HRSA will find you to be out of compliance. And I tried very hard with them to convince them it doesn't make any sense, and they kind of agree, but they said it's too bad, that's what it says, so you have to have it there. So I will tell you that one of the pleasures of being an attorney is having to call up the attorney on the other side and say, I agree with you, this does not make any sense, but I still need to have it in here because HRSA requires me to have it in here. So that's one of the fun and additional reasons to have an attorney helping you with preparing for this. Another tip for you, when you get beyond the required services, additional services, so many FQHCs have certain additional services on there because they've had them on there for years. There is no requirement to perform additional services. So if you were previously doing psychiatry and now you don't have a psychiatrist anymore, you don't need to get someone in column 3 to be able to say you send it out. You can just take psychiatry off your Form 5A, period. Now, again, don't wait till the day before HRSA comes because that will take you too long, but you do not have to have those services on. Okay, other things. So something new that's required is, so you have patients who come in who speak a different language, right? And so most places have a procedure in place for how to deal with that, right? You have a language line, you have people who are bilingual, something like that. Now there's a new requirement that you have to have an interpretation and translation plan. It's not just a procedure for how you do it. You have to actually have a written document that describes how you're going to do it. Everything we're going to talk about today, any document that you need, we have samples of, so I'll just mention you don't have to be panicking now about how am I going to do this. If you want to reach out, we have samples of all of these. Another new requirement is that you have to provide cultural sensitivity training. So I think this is something that makes a lot of sense, but there was never a requirement to actually do the training. And like any other training you have to do for HRSA, the training didn't happen unless you could provide documentation that it happened and people have signed in and you could show proof of it. Okay. Make sure all the services you perform are listed someplace on Form 5A. Okay, because what will often happen is that you realize I'll be sitting with clients and say, okay, tell me what services you provide, and then I'll go on your website and I'll realize there's a service listed on your website which is not on your Form 5A. So make sure that any service you provide is actually listed on your Form 5A, first of all, for HRSA purposes, and second of all, for FDCA purposes. If you provide a service and it's not on Form 5A, you will not have FDCA coverage for that service because it's not considered to be in your scope. One of the other things that that HRSA is become a big stickler on is the sliding fee requirements in column 2 and column 3, but more of a focus on column 3 agreements. So what HRSA wants is that historically what they said is as long as the other entity had a sliding fee, a charity care program, anything like that, like you contract with the hospital, they have their own charity care program, that was okay. Now what HRSA is looking for, and this is very recent, is evidence that you've gone back and looked at that and determined that it's at least as good as your sliding fee policy. And if it's not, that's not okay. So they want to see evidence you've looked at it. They want to see what, that you've done it. They did mention, and this is not written in any guidance, but they did, like I say, tell us that they will accept what they qualify as a good deal. So that the other entity may not be willing to agree to your sliding fee, but if they will give you a good deal. Now I can't give you parameters for that. HRSA didn't give parameters, but for example, you're sending somebody out for drug and alcohol rehab, and they normally charge the patient $1,000 for their service, and they are willing to cut it down for you to $50. Right? So even though $50 might be higher than your sliding fee, that's a really good deal. So you might be able to get away with that. And so one of the questions I asked HRSA is, okay, so in the real world, right, there are not many providers out there who are all that interested in taking our even Medicaid patients, but definitely our self-pay patients. And so what do you want me to do if I can't find someone who actually will take them, or if I find someone but they have a higher sliding fee than me? And what they said is what they want, which I disagree with, but I just have to tell you, is they want you to then make it into a column 2 agreement and you pay for it. Now you could pay the difference to get it down to your sliding fee. You don't have to pay the full rate, but if they're only willing to agree to a higher sliding fee than what yours is, you would actually have to pay the difference to get them down to your sliding fee numbers. Okay, clinical staffing. So there used to be a requirement that the majority of the primary care staff had to be directly employed. That is no longer the case. Generally, you can contract for services. If you're contracting for everything, then you will have a problem, and HRSA will not be okay with it. But if you're contracting for limited services, then you are okay. But the big piece here is credentialing and privileging. So our experience has been that maybe after Form 5A, credentialing and privileging is the next highest item to get hit, because you need to have really detailed credentialing files, privileging files, and processes for approval, and you need to make sure that what you're doing makes sense for an FQHC. So, for example, you should not be giving hospital-type privileges, admitting privileges, right? Many facilities we've come to, it seems like have gotten the privileging document from hospitals, and they talk about outpatient privileges, inpatient privileges, admitting privileges. Those don't exist in an FQHC, right? Because you're an outpatient clinic, and so those things don't make sense. There are also many other details in how you're in credentialing forms and getting proof of character and competence and how you're reviewing character and competence, which I can't get into all those details today because that could be a webinar in itself, and maybe it will be a webinar in itself. But what I would tell you is this is an area you very much need to focus on. As something that could help you, if you go onto the HRSA website, or if you want to send us an email, we'll send it to you. But if you go onto the HRSA website, where they have the OSV guide and where they have the actual OSV question and answer, there is a document up there which is called something like Credentialing and Privileging Tool, which is like a 3-page chart that lists you what you need to have in each box for each type of provider. And so that's a good tool to be able to use. I will also point out you need to remember that you need to credential pretty much anybody who touches a patient, or in case of social workers or somebody like the behavioral health, don't touch a patient but are direct clinical providers. But with regard to medical, that includes MAs, it includes nurses, all those people need to be credentialed. There are separate categories of what you need to do for them. For anyone who touches a patient needs to be credentialed, even if in your state medical assistants are not required to be credentialed or licensed by the state. HRSA still requires that they go through a credentialing and privileging process. Okay. So I think we've talked about that. Oh, so one other point I'll make is one of the things you have to do is verification of clinical competence, right? So what HRSA has said is that you can do that through peer review. So that if you have a provider who's been with you for 10 years and now every 2 years you have to re-credential them, you don't have to go out and hire an outside company to do a peer review of them, and you don't need to go back to their school and ask, where they were trained for that now that they're existing providers. You can do it internally through a peer review. Also, something very important, the last bullet point on the screen. This is a major change, and the people doing your credentialing and privilege will be very happy with this. There used to be a requirement that anyone who worked in your site had to be credentialed and privileged. However, what HRSA has changed, so if you think about, if you contract with a hospital and the hospital is sending you over providers on some kind of leased employee or services arrangement, the hospital is already credentialing those people. So what HRSA has said is that if you are getting people from an entity that credentials people, now if you're getting them from a private practice, it's not going to work because private practices don't credential, but if you're getting them from a hospital or something like that, and they're being leased over to you, you do not need to separately credential them. You could just have language in your agreement, which again we can provide you with, that says that the hospital is credentialing them and agrees to provide you with documentation that you need relating to it if necessary. Okay, next one is hours, locations and hours of operation. So this is a pretty straightforward one. They want to make sure that you have your hours of operation and that they are appropriate for your patient population. Now, what HRSA would really like to see is that you have some evening hours and or weekend hours. Now, in some of the FQHCs we visited, there is a real concern about having evening hours because the area gets dangerous at night and the staff is concerned about coming out. In most areas that's not the case, but there are some areas like that, and so that could be an explanation that you provide for not doing it. I would actually document that in the minutes if you're not going to have evening hours or weekend hours. But what you need to be doing very definitively is have to make sure the board is approving these on an annual basis. So what we actually advise clients to do is take a piece of paper, put on there all your sites, all the hours, and what services are provided at each site, and put that in front of the board at least once a year and have the board approve it. You also need to show, so the last bullet point that's up here, HRSA never used to focus on, and now they are focusing on. So they want to see from you, I don't care if you have weekend hours, you have evening hours, they want to see from you how you are getting feedback from patients as to whether the hours are sufficient or you should be expanding them or adding more services or things like that. So one way to do it is to do a patient survey. I'm not saying you need to do a patient survey, but what you can do is if you're pay attention to it is, number one, you could have this, pose this question to the patient members on your board. And number two is, as part of your QA and risk management activities, as things are coming up where people are complaining about hours or talking about it, you can pull some of that out and put it into a report and put that report in front of the board periodically. Okay, so coverage for during and after hours. So this has changed because it used to be that the requirement was only for coverage after hours. Now it's for coverage during hours. You might say to me, what does coverage during hours mean? Right? What that means is if a patient walks in to the front desk and collapses, what are your policies for dealing with it? So many places will have code blue or similar type emergency policies. Well, actually, I'd say many places have those procedures, because when I ask about it, of course, yeah, we call it code blue, we call the doctor, this is what happens. And my next question is, okay, do you have anything in writing? And like I mentioned earlier with regards to interpretation plan, under the new manual, you must have this plan in writing. You must have the plan in writing for during hours and for after hours. Okay, importantly, they add another requirement, which is that you have to have at least one staff member who's certified in BLS present at each site anytime the site is open for patients. So you might say to me, well, of course that's the case, because you always have a doctor there or a physician, or a nurse practitioner or a PA. But in many places, you are doing behavioral health. So if you're doing behavioral health and you do not have medical during those hours, most likely the behavioral health providers will not be BLS certified. So it's something you need to look into and make sure that you do have a BLS certified person there. Okay, so this is one that HRSA is going to test. So they want to make sure that after hours, if there actually is someone answering the phone and patients are able to determine that service exists. So that means having an answering service. It also means having people on call. But one of the, things that improved is HRSA used to be a stickler, and which never made any sense to me, right? They wanted you to have a sign on the front door of your center saying, after hours, this is the number to call. Because the only thing I could think of is they thought at 3 o'clock in the morning, someone who knows that you're only an outpatient clinic that's open from 9 to 5 is going to drive to the door to see the phone number to be able to call you at 3 o'clock in the morning. And if you didn't have it in the past, they would cite you and find you out of compliance. They've now become a little bit more rational about it. So you need to have some process for notifying patients of it. The process can be that it's on your website, right? Something on your website saying 24 hours, call this number, for emergency, after hours, whatever, something on your website saying that. You could have it in your patient areas as well. They don't tell you how to do it, but they tell you have to be able to show that you did it. So one of the things that we often find, people say to me, we have it in our patient brochures. And I'll say to you what HRSA will say to you, that's great for the new patients who came this year. The patient who's been there 20 years ago, if they took a brochure 20 years ago, if you even had a brochure 20 years ago, threw it away in the garbage 20 years ago and hasn't seen it. So that's not sufficient notice for it. Okay, so one of the other things that we often find is a problem is your main number will roll over to the answering service, but you might have 20 other numbers that patients call. The pediatrics department has its own number, and patients regularly call that number. That number does not roll over. So you got to make sure that that is rolling over. You need to make sure also that your answering service has someone who can speak whatever language. Well, I don't say whatever language. Someone who could speak the languages your patients will call. I glossed over this before when I talked about interpretation. You need to have some kind of language line where even not the common language, the patient comes in and speaking some unusual language, you have an ability to get on a language line and have someone on the other end and be able to translate. Today is not about FDCA, but from FDCA standpoint, and risk management standpoint, I will tell you, do not be using a family member to translate because very often things will get lost, especially if you're talking medical terminology. They may not know how to translate those words. So if you're using a staff member or clinician, that's okay, or if you're using the language line, but generally those are the only two options. But after hours, there needs to be an ability to have access to the language line as well. I will also tell you that not from a HRSA perspective, but from an ADA perspective, you need to worry about people coming in who need sign language or otherwise are impaired, and what you're going to do for that. And there are many services now where the language line is not actually a phone, it's actually through a tablet or something like that, where there's someone on the other side, so they actually could be seeing the patient and be able to deal with patients who are deaf or otherwise impaired. The outside answering service must go into column 2 on Form 5A. And you must have a contract that complies for it. Okay, the next is about having continuity of care hospital admitting. So they would like for you to either have some of your doctors who have hospital privileges, or that you have some other arrangement to take care of your patients when they're in the hospital. So in most FQHCs, maybe if you put aside if you're doing deliveries, but most other providers don't end up going to the hospital. And so you need to have an arrangement with the hospital where they're covering for your patients. You need a coverage agreement with the hospital, which has to have her special HRSA magic language in it. Also, this comes up here, and it comes up with regard to risk management. You need to be able to do hospital tracking, right? So what that means is, now this has changed dramatically for the better. Right, the requirement used to be that you needed to know about any of your patients who was in the hospital and know their status. And so what FQHCs would try to do, which I'm sure many of you have had the experience of doing, is go to the hospital and get them to sign an agreement saying they're going to notify you about any of your patients who are in the hospital. And I would imagine that the overwhelming majority of you got the same pushback, which we always get pushback, which is the hospital saying, are you out of your mind? I have to run a hospital here. I can't be busy figuring out which is your patient and reporting to you about your patient. If you tell me which patient is yours, maybe I can give you a report and you could be able to do it that way, but I can't tell you that the person is your patient, because many times the person will come in and will say, yeah, I'm Dr. They ask you who your doctor is and say Dr. Smith. They won't say ABC FQHC. So HRSA has now changed this and made it a lot better. What they've now said is that if you FQHC send the patient to the hospital, you tell them, the patient calls you and say you have to go to the hospital. They're in the clinic and you tell them they have to go to the hospital. Those are the only times you have to track those patients. That makes it a lot easier. Of course, it still means that you need to have a process for tracking that. And so in most FQHCs that we've been working with, we've set up a process where you have a designated person whose job it is to track. But then what that requires is that the clinician seeing the patient has to actually create a hospital tracking referral or create something in the system to be able to know that you're following up for someone to follow up, because if they just put it in their notes or don't put it in any place, you'll have no way to be able to do it. I will also talk about now for 2 minutes, even though it's out of order because it's on this slide, referral and diagnostic lab tracking. So HRSA wants you to be doing referral tracking. So that means you give a patient an order to go get an x-ray or to go get a lab. Are you following up with them to make sure that they actually went and did it? Or you give them a referral to go to a cardiologist. Are you following up the patient to make sure they actually went? Now you might say, I don't know what you want from my life. I have a hard enough time taking care of my patients. I gave them a referral. It's their job. And they should be responsible enough to go by themselves. And I don't disagree with you, but I'll tell you that HRSA disagrees with you. And HRSA says, no, that's not okay. You need to be doing follow-up. Once I'm loading on you, I will also tell you that as part of risk management, HRSA requires that you have a policy dealing with no-shows, meaning the patient didn't show up. What are you doing about following up with that patient? Now, I would say that we split no-shows into 2 different buckets. So depending on where you are, if you're in a inner city or someplace like that, or with a population where you have many, many visits in a day, many places will have that in the morning you'll get 20 calls from parents saying their kids are sick. Could they come in this afternoon with the kid? And then by the time the afternoon rolls around, 5 of them will not show up because the kid starts to feel better and they're like, I don't want to waste $25 to go in, or the kid's just feeling better and they don't bother to show up. I'm not telling you that HRSA would agree with this, but as a practical matter, what we've seen is that in those cases, you're not necessarily doing follow-up. Where you're doing the follow-up for a no-show is more where you have a patient who comes in, is an 85-year-old woman who has heart condition, and comes every Tuesday morning, and she's supposed to come this Tuesday, and she didn't show up. What are you doing about it? Right? I will also say that HRSA is a big stickler in the FDCA world, where with regard to, so something is similar with regard to lab or diagnostic results, right? So you get the results back on a patient. So what many FQHCs tell me is when we get the lab results back, we only call the patient if there's a problem. If there's not a problem, we don't call the patient. They might say, we tell the patient that when we see them. I will tell you that HRSA is not okay with that. And I will tell you that I think you should think about it as a patient, right? Because as a patient myself, when my doctor tells me getting back to me about lab results, if he doesn't call back, until he calls back with the lab results, I'm sitting on edge, waiting to make sure that everything is okay, even though you know it should be okay, but you're still worried about it. And so as a patient, I would never want to go to a practice where they didn't call me back and tell me what my lab results were. But regardless of whether you feel that way or not, HRSA says you need to be doing it. They also say it to the extent that, let's say you get back bad lab results and you try reaching the patient and the patient doesn't call back, right? So you leave a message on the patient's voicemail. What HRSA wants is that if it's an emergent kind of condition, you have to have some other way of tracking down the patient. Maybe you could call their representative, whoever they list as, the next person to call. If you can't reach that person, they actually want you to be calling the police or some ambulance service or something like that to go track down the patient to tell them they have a very serious condition. Okay, sliding fee. So sliding fee is another one of the topics that really could be an entire presentation in itself, but I will just give you some highlights. Okay, so one of the things that you need to do is you need to have a sliding fee policy, and under the new requirements, there has to be below 100%, no more than a nominal fee, and then between 100 and 200%, 3 different categories that you apply, and the rates that you're applying in each of those categories have to be different. So if you want to just say that anyone under 100%, we charge $10, anyone between 100 and 200%, we charge $20, that's not okay. You actually have to have 3 separate categories between 100 and 200%. I can't explain to you why, I'm just telling you that's what HRSA says. You could pick, right, if you want to do 100, 133, 166 to 200, well, you could pick 100 to 110, 110 to 120, and then 120 to 200. They don't tell you where those 3 categories have to be, but you have to have 3 separate categories. It has to be different amounts. The slide is up to you to determine. It can be a fixed dollar amount or it can be a percentage. So you can say that we give an 80% discount, a 70% discount, or we can say we charge $20 or $25. Either one of those is okay. The board has to approve them at least once every 3 years. It has to be reviewed and approved by the board. It no longer has to be every year, although practically you have to do it every year because when they update the federal poverty guidelines each year, you're going to need to change your policy and go back to the board. Something important. So when I started doing this, part of my, I'll say, sick fun is I'd walk in and start asking people about sliding fee and who does it apply to, and everyone tells me, yeah, it applies to the self-pay patients. That's true that it applies to self-pay patients, but under the new guidelines, it also applies to patients with insurance. So if someone has insurance, but they have a deductible or a copay, and they're below 200% of the federal poverty level, you have to slide the deductible or copay, which means that historically, places that only talk about sliding fee to patients without insurance can no longer do that. You have to make it available to patients who have insurance. Now, you don't have to ask every patient. You could have a sign up saying, sliding fee discounts available. Please speak. Please inquire if you want. But that can't be limited only to patients without insurance. Okay, so if the patients are above 200%, HRSA does not allow you to give a discount with one caveat. So I always tell the story. I don't know if you ever heard it before, you might have heard it, but I think it's very relevant. We had I'll say, hospital-based FQHC that was eligible to participate in the charity care pool. The charity care pool, they were going to make out of that $3 million for 1 year, was what their distribution was going to be. But the state that they were in said in order to be in the charity care pool, you have to give discounts up to 300% of the federal poverty level. And HRSA came and said we can't give discounts above 200%. And we figured out that over the course of the year, they gave $700 worth of discounts between 200 and 300%. And so we had a conversation with HRSA, and we said to them, okay, so let me get this straight. Because we're giving $700 in discounts, you want us to give up $3 million that we're going to get from the state charity pool. And HRSA said, not only do I want you to do it, if you don't do it, I'm going to take away your FQHC. So as you can imagine, when $3 million are at stake, it's nice as an attorney to have these clients once in a while. This client was willing to fight with HRSA. And so we went back and wrote letters and told them, show me where it says that and prove it and all these things. Based on that, when the new compliance manual came out and part of other sliding fee materials, HRSA has now said that you can give a discount above 200% if you have a different grant source that's going to cover it. You cannot use your $330. You cannot use your Medicare and Medicaid dollars. You can't even use your commercial dollars. You need to have a different source, someone else giving you money. But if, for example, the hospital down the block says, I want you to give discounts up to 250%, and I'll give you a grant to cover those, you can do that as long as you have another source. Okay, sliding fee discounts, again, you have to make patients aware the same way as you have to for after hours. You could either do it through signage in the waiting areas. It could be on your website. There's different options for doing it. HRSA does not mandate how you do it, but just that you do it. Okay, QA. So when people ask me what's the biggest difference between an FQHC and a private practice, I tell them it's quality assurance, right? So in a private practice, what you're doing is you're trying to take care of the patients, get them in and out as fast as possible, fill as many visits as possible, and not really worry about totality of anything. In FQHC, you're looking at the totality of things, you're looking at the quality, you're trying to improve the quality, you're trying to make sure that you're looking at all the patient's needs and not just the episodic thing they came in for. So HRSA, I think, views it the same way as QA being the most important part of what an FQHC does. And so because of that, they spend a lot of time focusing on it. So you need to have a QA policy plan, whatever you want to call it, a written document that has to go through all the things that are up here. I'm not going to go through each one of them, but I'm just going to mention a couple of them. Patient satisfaction, you need to be doing patient satisfaction surveys. Again, HRSA does not mandate how you're doing the surveys, but you need to have some kind of survey that you are doing. You need to have a grievance process, right? So one of the questions we get often is, what does a grievance mean? So a grievance does not mean, so there's a formal grievance and an informal grievance, right? Someone coming to the front desk and saying, I've been waiting for 45 minutes already, when am I going to go, does not necessarily rise to the level of a grievance. Someone saying, I want to put this in writing and make a formal complaint does rise to the level of a grievance, right? A person coming back and saying that a staff member harassed them is something that will rise to the level of a grievance. So it's the basic rule of thumb is things that you could resolve easily on the spot, you probably don't need to put into your grievances, but things that you require additional work or additional response beyond that would generally qualify as grievances. Okay, they want you to have clinical policies as well. So I'm going to give you an easy trick for clinical policies, right? So some places I go to have 1,000 pages worth of clinical policies, and I say, that's great. What about the clinical policy on this? And so it's not possible to have a clinical policy on everything. So you can have some, but what I would tell you is you want to have a policy that says something like, so if you're familiar, there's a product called Up to Date, which is a web-based product that has all the most current guidelines based on AMA and American Dental Association and any other associations, ACOG, that are out there. And so you could use that as your basis. You still need to have a policy that says that, but that could be the basis for your standards. If not, you can make reference to national organizations as the basis for your standards, the things that are not covered in your policies. So QA, you need to have a QA committee, right? You need to designate who's on that committee. It really should be representatives of all significant departments. You need to have at least quarterly meetings. You need to be reporting to the board at least on a quarterly basis. You need to have meeting minutes. You need to be checking measures. Hopefully you're checking your UDS measures. You're reporting on them and reporting on things that are good and bad and ways of improving. I will tell you that a very strong recommendation, because when we get to risk management later, so the line between quality assurance and risk management is very blurry. most things that fit into one also fit into the other. And so what I would strongly recommend is that your QA committee be called your QA/risk management committee, be a joint committee that covers both. Even though some of the topics might not fit for the other, as long as you have them both together, you're now covering both QA and risk management. Because we all know that at the end of May, beginning of June, when you have to do your FDCA application, you're going to have to be able to show minutes. And we get this panic before, people saying, I can't show any minutes. And so I'm giving you an easy way to do it, which is make your QA minutes both your QA and risk management minutes. One of the other things that comes up is someone says, well, we don't report to the board, but we have a board member who sits on our QA committee. That is not sufficient. It's fine if you want to have a board member sit on the QA committee. There actually have to be reports to the board of your QA activities. Okay, next is key management staff. So this is basically your table of organization. What they want to see here is that you have enough people in place to be able to actually manage your operations. My experience has been that actually most FQHCs are understaffed rather than overstaffed like hospitals, but that the reason why that's the case is you don't have enough money to be able to hire enough staff. But make sure, at least on your table of organization, you're covering all the main positions, and make sure that it makes sense. So I have someone in my office who is the expert at tables of organization, because we will often find that you have like the CMO reporting to the director of nursing, right? So a doctor can't report to a nurse. Or you'll have a clinician reporting to a non-clinician. You can't have that either, right? You can have them reporting for administrative purposes, but not for medical purposes. Also, very important, and in many states, the state wants the compliance officer to report directly to the board, not through the CEO. So what I'm going to advise you is that you have a table of organization that you use when the state asks you, and you have a separate one you use when HRSA asks you, because HRSA does not allow that. HRSA says that the only person who can report to the board is the CEO. The only person the board has authority over the CEO, but no one else can be a direct report to the board. Now that does not mean, so I don't get a million questions, that you can't at a board meeting have the CFO present a report to the board. Of course you can. But from an organizational perspective, you cannot have a direct reporting line from the board to anybody other than the CEO, from anybody other than the CEO to the board. It's something that's very important. I will tell you another tip. When they come in and talk to your board during the OSV, they are definitely going to ask your board this question. Who can you hire and fire? Who reports to you? Just to jump back, something I mentioned at the beginning, because people are asking questions, these slides will be sent out with a recording tomorrow, so you don't have to worry about taking pictures of all the screens. Okay, contracts and subawards. So basically what this deals with is if you're using federal grant dollars for procurement purposes. So I want to be clear. If you're going out and buying something and you're not using federal grant dollars, using your regular dollars that you get in from serving patients, these rules do not apply. So I would strongly, strongly, strongly encourage you to only use federal grant dollars for paying salaries, right? You need to do time and effort reporting for that, but you don't have to worry about all the crazy procurement rules and getting 3 bids and keeping records of everything and doing all those kinds of things. So unless you're getting a construction grant or an equipment grant where you don't have a choice, you should not be using grant dollars for those purposes. If you have to use grant dollars for those purposes, like in the example of a construction grant, then there are very detailed rules for that and policies you have to have, depending on how much you're spending and whether it's a sole source and why it fits, and you need to keep very detailed records, and the details of that are beyond the scope of this presentation, but I'm happy to talk to anyone who wants to go over those. Okay, conflict of interest. So people think of conflict of interest, right? That basically means, do I have someone who we're buying products from that we have a relationship with? And so people think of this as being only a board requirement. It is not only a board requirement. It applies to senior management, and it also applies to anyone. It could be someone much further down the food chain, but anyone who's involved in the purchasing process. So you could have a purchasing director who's the 9th person down on the table of organization, but because they're doing purchasing, they need to fill out and need to check their conflict of interest, because obviously they're purchasing. They could be purchasing from someone they know. So you might tell me, oh, this never comes up. I will tell you a war story. we had a nursing home that we represented, we came in to represent, and they had been in business for many years, and we found out that the chair of the board had a laundry business, and it turns out that not only was he getting their business, he was charging them triple the going rate. And so those are the kinds of things you're concerned about and you're worried about, and you want to have reporting on. You need to review this periodically. It means at least every 3 years. You need to have people fill out statements on an annual basis, okay? You actually have to have the people fill out the form. I can't tell you how many times we get forms back. The person just signed it at the bottom and didn't check off the boxes, or checked off yes instead of no. They just checked off yes in every single box that they have a conflict for 10 different reasons, right? They got to read the forms and make sure that they're filling it out correctly, so you're not just sticking, the inappropriate forms in front of HRSA. Okay, collaborative relationships. So this is something HRSA never used to check, but now they are checking. They want to see that you have relationships with other providers in the community. It could be other FQHCs, does not need to be other FQHCs. It could be hospitals, community stakeholders, anybody like that. It could be your PCA. It could be your local health district. But they want to see some written collaboration documents. And it could be a stupid one-page letter that says, yes, we agree, we're going to work, going to think about ideas to work together on. That's fine, but they actually want to see you having some of these, and they actually ask for it nowadays. Okay. The next is financial management accounting systems. So, like I said, each of the financial things could be their own presentation in themselves, but just high level. What they are looking for here is that you have systems in place to be able to keep your money safe. So, for example, when you have cash you collect at the front desk, how do you make sure that that cash is actually getting into the bank and not ending up in somebody's pocket? And I love when I come into centers and they tell me that it's impossible that anyone ever took money and put it in their pocket. If that's the answer that you're giving, then you should know that you're wrong and you're not really looking closely enough, because it's virtually impossible to ensure it, right? So you could have things in place to make it better. But so for example, and this is actually a good standard to have, but I just want to give an example, right? You tell me that we give the patient, when the patient gives us $10, we give them a receipt for $10. So if you're taking a handwritten receipt and giving it to the patient, is someone going back on the other side and checking the receipt book to make sure that's the case? Number one. Even if you're giving them an electronic one, how many times in the course of a day do you go into a store or someplace else and someone gives you a receipt and you take it and throw it straight in the garbage or crumple it up and put it into your pocketbook and never look at it again, right? So saying to her that it's impossible someone stole is just silly. Those are good standards. If you're giving out a receipt from the electronic system and you're tracking it, that's okay, but don't take a position that is not justifiable. But anyway, you need to have processes for that. You need to have processes for purchasing, right? The person who's doing the ordering should not be the person who's doing the receiving, because what's to stop them, in September when school is starting, from ordering 10 extra boxes of pencils and pads and all those things and taking them home to give their kids to take to school? Because generally when you say we do our reconciliation through our accounting system, they're not looking on a line item basis. They're looking on overall, does it make sense? Last year we spent $200,000 on supplies. We spent $200,000 on supplies this year. We're up $205,000. I'm not going to get crazy about it, but that $5,000 might have been through things that were taken for inappropriate purposes. You need to have an annual audit. Okay, we talked about some of these things. So one of the major problems we find with regard to financial management is that you have policies which are fantastic. They're written, very well written. You got it from your accountant, whoever else, and they're wonderful. Except for when I sit and ask questions, it turns out the policies have nothing to do with what you do in real life. So having great policies, HRSA is going to ask questions about the policies and test them. So you got to make sure your policies actually comply with what you're doing. You also have to be reporting on this to the board. There is a new requirement that if you are doing capital expenditures, you have to have a capital expenditure plan which is approved by the board. This is something brand new, so if you never did in the past, you never required to do in the past, something new you need to be developing. Okay, billing and collections, you need to have a process for it. You need to be careful with wrap billing and things like that to make sure you're doing it appropriately depending on the state you're in and you're keeping regular records of it. You also need to determine whether or not you're going to have policies based on refusal to pay or inability to pay. So the difference between those, inability to pay means I don't have enough money to pay. Refusal to pay means I know that you're an FQHC and therefore you have to provide services regardless, so therefore I'm going to tell you I'm not going to pay. In that case, you can turn the patient away and say, get lost, we're not going to treat you. Okay, budget. You need to have an annual budget. If you have separate lines of business not part of your scope, then you need to have a separate budget for whatever is in scope. The board has to approve it. You need to do regular reports. Okay, it seems like a really silly thing here, but it's very important. If HRSA wants to see pictures, they want to see you showing charts and diagrams. I think they think that the board members can't understand numbers and might be able to understand pretty pictures. So throw some pretty pictures into your financials. Okay, UDS reporting. Hopefully you're doing this and you have a system to do it. I know that January and February, we can never call anyone at FQHC who's involved in UDS reporting because it's a pain to do. There are some systems out there that can help you do it, but importantly, you need to be using that data to report back at your QA committees and to your board. Okay, board authority. So you need to have a lot of different things the board has to do. Within your bylaws, they will tell you that in the bylaws themselves, there's probably 100 changes that need to be made because HRSA has changed the words and changed the overall board responsibilities, not much on a substantive level, but on a wording level. They have changed, like I say, the board only has to approve certain policies, basically the financial policies and QA policies, risk management, not all policies. There's no longer a requirement for the board to do an annual self-evaluation. The board does not have to review the CEO each year anymore. You have to do it once every 3 years. You need to have a 3-year long-term, long-range planning plan, actual document, not just doing it. There's a big focus on QA, like I mentioned. The board has to also evaluate your performance. How do you do that? Generally, it's through having an attorney or consultant come in and do a presentation explaining what the requirements are and how you comply with it, which is something that we do. Okay, if you need to have monthly meetings. If you miss November and have 2 meetings in December, that's not okay. There has to be a monthly each month, and if you do not have a quorum, that is not considered to be a meeting. A tip for you is don't schedule your meeting on the last week of the month if possible, because then if it snows or people get sick or people can't come, you don't have any days to be able to make it up. So it's better to do it a little bit earlier in the month to give yourself leeway in case you need to change it. Also, all the things the board needs to do, most FQHCs end up doing it the month before HRSA comes. That's okay. It would be a lot easier if you actually spread it out. With regard to board composition, it pretty much stayed the same, except that HRSA has now clarified that to be a patient means you have to have had 1 visit within the prior 24 months. It does not have to be the primary place where you provide services. Obviously, that's better if it is, but it does not have to be that. So anyone could be a patient, patient board member as long as they have 1 visit within 24 months. You still need to comply with demographic factors, race, ethnicity, gender, to be able to comply with those. So you can't put, depending on where you are, 9 white men on your board, but you could put people on your board who otherwise would not have been patients, but just become patients by having the 1 visit. Okay, also how you define healthcare industry has changed. You can now define it yourself and you can limit it to clinical providers. I am running out of time, so FDCA, we talked about this. They want you to have a lot of policies in place, risk management policies. They want you to be able to show that you did training for everybody, and we did a risk management one a couple of months ago, so I'm not going to go over all those details again. Just quickly about us, so like I mentioned, we've done the OSV under the new compliance manual with more than 20 FQHCs. 75% of them have had 0 or 1. Almost all the rest of them had 2 or 3 for the items on which we assisted. We provide mock services. Generally, that means coming in for a day and meeting with all senior management, asking the same questions the surveyor would ask, and then based on that, we will then tell you what we think you need to fix for it. So just a sample agenda, and this will be in the slides that comes out to you. We go through all the different items. Like I said, we meet with whoever you want. At the end of the day, we give you a verbal of what needs to be done, and we can give you written documents and a written plan for how you're going to comply. I mentioned earlier that there's 29 documents that need to be updated because of the compliance manual. Here is a list of them. Again, you don't need to take a picture. You'll get this in the slides tomorrow. We also provide many trainings. We do these things either in person or we do it through, through the computer. So you don't have to actually pay us to come in person if you're far away. But we offer those either way if you want. Okay, so we did not get to the questions. I apologize. For those of you who submitted questions, we will send you answers separately. Thank you for joining, and have a good day.